Good morning, everyone. Welcome. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is April 20th, 2022, and I'm pleased to call today's ACIP meeting to order. I will first turn it over to Dr. Melinda Wharton to share today's announcements.
Thank you, Dr. Lee, and good morning. Next slide, please. So we'll start with a few meeting logistics. Welcome to the April 20th virtual ACIP meeting. Copies of the slides being presented at today's meeting are available or will be available soon on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex-officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. And when Dr. Lee opens the meeting for discussion, please use the raise hand function to virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex-officio members and liaison representatives. As always, please disable your video, but we do ask that ACIP voting members turn on their video during the votes. Next slide, please. The Advisory Committee on Immunization Practices is at its heart a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding one oral public comment period today at approximately 2:15 p.m. Eastern Daylight Time. To create a fairer and more efficient process for requesting to make an oral comment, we request that people interested in making an oral comment submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0051. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the Advisory Committee on Immunization Practices agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstain from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. And finally, a very important bit of information to share. We are currently soliciting applications and nominations for candidates to fill upcoming vacancies on the Advisory Committee on Immunization Practices. Detailed instructions for submission of names of potential candidates to serve as ACIP members are now available on the ACIP website. Applications for ACIP membership are due no later than July 1, 2022 for a 4-year term beginning July 2023. And with that, the announcements are concluded, and I will turn the podium back over to Dr. Lee.
Thank you, Dr. Wharton. And I just want to put in an extra plug, echoing the encouragement for individuals to apply for ACIP membership. For our ACIP members today, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. And today we will start with Ms. Lynn Bata.
Good morning, Lynn Bata, Immunization Clinical Consultant at the Minnesota Department of Health, and I have no.
Thank you, Ms. Bata. Dr. Bell?
Good morning, Beth Bell, Clinical Professor, Department of Global Health, University of Washington. No conflicts.
Thank you. Dr. Brooks?
Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation. Good morning, and I have no conflicts.
Good morning, Dr. Brooks, and thank you. Dr. Chen?
Wilbur Chen, Professor of Medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I have no conflicts.
Thank you. Dr. Saneas?
Good morning, Sybil Taneas. I am an internist and pediatrician, Associate Professor of Medicine and Pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you, Dr. Saneas. Dr. Daly?
Good morning, Matt Daly. I'm a senior investigator at the Institute for Health Research at Kaiser Permanente, Colorado, and also an associate professor at the University of Colorado, and I have no conflicts.
Thank you. Dr. Cotton?
Good morning, Camille Nelson Cotton. I'm the Clinical Director of Transplanted Immunocompromised Host Infectious Diseases at Massachusetts General Hospital and Associate Professor at Harvard Medical School. I have no conflict.
Thank you. Dr. Lair?
Jamie Lair, family physician in private practice in Ithaca, New York. I have no conflicts.
Thank you. Ms. McNally?
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez?
Hi, this is Pablo Sanchez. I'm a professor of pediatrics at The Ohio State University College of Medicine and Neonatology and Pediatric Infectious Diseases at Nationwide Children's. Thank you. I have no conflict.
Thank you, Dr. Sanchez. Dr. Talbot?
Good morning. I'm Kip Talbot. I'm an associate professor of medicine and health policy at Vanderbilt University Medical Center, and I have no conflict.
Thank you. Dr. Alt?
Good morning. My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Medical Center in Kansas City, Kansas, and I have no conflicts.
Thank you. And this is Grace Lee. I'm Professor of Pediatrics at Stanford University School of Medicine, Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health, and I have no conflicts. So we have quorum today and we can proceed. We will move on to the ex-officios and liaison members, and I will announce the organization name, and please indicate if you are present and your first and last name. We'll start with the Centers for Disease Control and Prevention. Thank you, Dr. Posner. Center for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hans for CMS.
Thank you, Ms. Hans. Food and Drug Administration.
Good morning, Doran Fink, present on behalf of the U.S. Food and Drug Administration Office of Vaccines.
Thank you, Dr. Fink. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, HRSA.
Thank you. Good morning, Dr. Rubin. Indian Health Service.
Good morning, Dr. Matthew Clark, representing IHS.
Thank you, Dr. Clark. And National Institutes of Health.
Hi, this is Seema Nayak from National Institutes of Health.
Thank you for joining. Next, we will move on to our liaison representatives, the American Academy of Family Physicians.
Good morning. Pamela Rockwell, Professor of Family Medicine at the University of Michigan Medical School, AAFP Liaison.
Thank you. American Academy of Pediatrics.
Good morning. This is Dr. Bonnie Maldonado, and I'm Professor of Global Health and Infectious Diseases at Stanford School of Medicine. I'm also the chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you, Dr. Maldonado. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the AAP Red Book.
Thank you. American College Health Association.
Good morning, Sharon McMullen for the American College Health Association.
Thank you. American College of Obstetricians and Gynecologists. Okay, we'll come back. American College of Physicians.
Good morning, Dr. Jason Goldman, General Internal Medicine, Private Practice, Coral Springs, Florida, Affiliate Associate Professor, Florida Atlantic University, representing American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Ken Schmader for AGS.
Thank you. America's Health Insurance Plans.
Got Bob Gluckman here.
Thank you. American Immunization Registry Association.
Good morning, Beth Perilla for the American Immunization Registry Association.
Thank you. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Good morning, Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association.
Good morning, and Stan Grog, present for the AOA.
Thank you. American Pharmacists Association.
Good morning, this is Michael Hogue, Dean and Professor, School of Pharmacy, and Professor of Preventive Medicine at Loma Linda University, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Good morning, Rob Schechter, AIM. Thank you.
Thank you. Association for Prevention, Teaching, and Research.
Good morning, Christy Mullion-Jessel, Assistant Professor at the Department of Family Medicine at the University of Pittsburgh, representing the Alternative Liaison for APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning, everybody. This is Nirav Shah. I'm the ASTO President and the Director of the State of Maine Center for Disease Control and Prevention. Thank you.
Thank you, Dr. Shah. Biotechnology Innovation Organization.
Morning, Joel Strauss, representing BIO.
Thank you. Council of State and Territorial Epidemiologists.
Christine Hahn, Idaho State Epidemiologist, present.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Shelley Gates, Chair of NACI.
Thank you. Infectious Disease Society of America.
Good morning. This is Jeff Duchin. I'm the Health Officer for Public Health, Seattle and King County in Washington State, and Professor in Medicine, Division of Infectious Diseases, University of Washington in Seattle.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, here for ISTM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACCHO, present.
Good morning. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield, representing NAPNAP.
Good morning. National Foundation for Infectious Diseases.
Morning, this is Dr. Bill Schaffner, Medical Director of the NFID and Professor of Preventive Medicine and Infectious Diseases at Vanderbilt.
Thank you. National Medical Association.
Good morning. This is Dial Hewlett, Deputy to the Commissioner of Westchester County Department of Health, White Plains, New York, and Adjunct Associate Professor at New York Medical College.
Thank you. Pediatric Infectious Diseases Society.
Good morning, this is Mark Sawyer. I'm a professor of pediatric infectious disease at UC San Diego and sitting in for Sean O'Leary, representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Maria Martin, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning, Amy Middleman, representing SAM.
Morning, and thank you. Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Drace, representing SHEA.
Excellent. Thank you. Are there any additional members who would like to announce themselves?
Good morning. This is David Kim. I represent the Office of Infectious Disease and HIV/AIDS Policy under the Office of the Assistant Secretary for Health, checking in as an ex-officio member.
Thank you, Dr. Kim, and welcome. Any additional attendees? Okay. I'd like to turn it back over to Dr. Wharton to provide a few opening remarks and to help set the context for our discussion today. So Dr. Wharton, the floor is yours.
Thank you, Dr. Lee. Again, welcome to today's meeting of the Advisory Committee on Immunization Practices, and thank you for joining us. The emergency use authorization is a mechanism that makes available medical products like vaccines more rapidly than would be possible otherwise. Since authorization of the first COVID-19 vaccine in December 2019, the emergency use authorization has made vaccines available to everyone in the United States 5 years of age and older. 2 of the authorized COVID-19 vaccines have gone on to be approved by FDA as a primary series in some populations. According to CDC's COVID data tracker, since the beginning of the program, 570 million doses of COVID-19 vaccines have been administered in the United States, and 256 million people have received at least 1 dose. This is a remarkable achievement, yet we know there's still more to do. Not everyone eligible has yet received a primary series or the first booster. vaccines are not yet authorized for the youngest children. There remains uncertainty about how to best protect the population with available vaccines, and we do not know what the future will bring in terms of emerging variants and what changes are needed in our vaccination approach in response to changes in the virus. In today's meeting, we are asking ACIP to discuss two of these questions: how to best use the now available second mRNA vaccine booster authorized by FDA on March 29th for persons 50 years of age and older, as well as for certain immunocompromised persons 12 years of age and older, as well as to look ahead to future use for COVID-19 vaccines in anticipation of updated vaccines that we hope will provide broader protection against future variants. As additional data become available on multiple fronts, we anticipate there will be more regulatory actions by FDA in coming months. For today's discussion, we are focused on the use of current and future booster doses, and we look forward to today's discussion. Thank you for joining us for today's meeting, and we're grateful to the members of the committee for their ongoing service during this unprecedented time. Thank you, Dr. Lee. I'll turn it back over to you.
Thank you, Dr. Wharton. And we will now move on to the first session for today. So Dr. Matt Daly, chair of the COVID-19 Vaccines Work Group, will provide an introduction and overview of the session today.
Good morning, everyone. I'll just wait a sec till the slides are up. Okay, perfect. Thank you so much. So I'm Matt Daly, and I'll be presenting today on behalf of the COVID-19 Vaccines Work Group. Next slide, please. So this graph shows daily cases, and in the U.S. to date, we've had over 80 million reported cases of COVID-19, and we're averaging approximately 35,000 cases per day at the present time. Next slide, please. Since the start of the pandemic, there have been almost 1 million deaths from COVID-19 in the country. And we are averaging approximately 370 deaths per day in the U.S. And it's important to note at this point that the U.S. vaccination program has likely averted hundreds of thousands of additional deaths. Next slide, please. So in this slide, what we're looking at is cases on the left and deaths on the right. I would highlight that the y-axis units change from left to right. And as you can see, the black line is incidence in unvaccinated. The broken blue line is incidence in vaccinated with a primary series only. And then the darker blue line is cases and deaths among those who are vaccinated with a primary series and with a booster dose. And then these data are summarized below. Unvaccinated people aged 12 and older had 3.1 times the risk of testing positive for COVID-19 and 20 times the risk of dying from COVID-19 in February of 2020. And updating data through March of 2022, again, those who are unvaccinated had 2 times the risk of testing positive for COVID-19 compared to people compared to people vaccinated with a primary series and a booster dose. Next slide, please. So what I want to do here is highlight the FDA updates that Dr. Wharton also referred to. On March 29th of 2022, the FDA authorized a second booster dose of either the Pfizer-BioNTech or Moderna COVID-19 vaccine for older people and immunocompromised individuals. A second booster dose of Pfizer or Moderna may be administered to individuals 50 and over at least 4 months after receipt of a first booster dose of any authorized or approved COVID-19 vaccine. And then a second FDA emergency use authorization said that a second booster dose of Pfizer-BioNTech COVID-19 vaccine may be administered to individuals 12 years of age and over with certain kinds of immunocompromise at least 4 months after receipt of a first booster dose of any authorized or approved COVID-19 vaccine. And then the third update from the FDA is as follows. A second booster dose of the Moderna COVID-19 vaccine may be administered to individuals 18 and over with certain kinds of immunocompromise, again, at least 4 months after receipt of a first booster dose of any authorized or approved COVID-19 vaccine. Next slide, please. And then in addition to the FDA updates that I highlighted on the prior page, there also was an emergency use indication or instruction. And the EUI mechanism allows the CDC to permit an emergency use of an FDA-approved medical product. And so on March 29th, and this should say 2022, on March 29th of 2022, CDC issued emergency use instructions for the use of both mRNA COVID-19 vaccines for people aged 18 to 49 who received a Janssen COVID-19 vaccine as both their primary series dose and their booster dose. These individuals now can receive under the EUI an mRNA COVID-19 vaccine at least 4 months after their first Janssen booster dose. Next slide, please. So just to highlight what I've talked about on the prior couple of slides, under the emergency use authorization from March 29th, this pertains to people ages 50 years and older, and then people 12 and older who are moderately or severely immunocompromised. And then the EUI is really specific to the circumstance of individuals 18 and over who received Janssen as both their primary and their booster dose. Next slide, please. So I'm going to spend a little bit more time on this schematic. So this schematic represents an overview of current guidance regarding the use of COVID-19 vaccines, including use of first and second booster doses, and this pertains to immunocompetent individuals. We also have a similar schematic that we'll see later that applies to the immunocompromised. And as you can see in the rows, this is vaccine product and age, and then you can see there are primary doses and then first booster doses. And then in the lighter blue is the second booster. And this is really our task for today. I think we all are being asked by patients, by colleagues, by our family, should I get a second booster dose now? And so what we're going to discuss today is we're going to review the data and then provide additional guidance to the public about who is most likely to benefit now from a second booster dose. And then in doing so, we'll also have an opportunity to look forward to the fall and what will be the framework for and the data needed for future doses of COVID-19 vaccines, as Dr. Wharton discussed in her introductory remarks. Next slide, please. So I do want to review the activities of the COVID-19 vaccine work group since we last met. So this summarizes our activities from February through April of 2022. We've reviewed data around the following topics. We've reviewed data on vaccine effectiveness for COVID-19 vaccines in children 5 to 11 years of age. We've also had safety updates in children in the same age group. In addition, we've reviewed survey data for intent to receive COVID-19 vaccines among children. We've also reviewed the safety and efficacy data from Novavax COVID-19 vaccine. In addition, we reviewed a series of presentations regarding infection-induced and hybrid immunity to COVID-19. We also looked at some additional data regarding vaccine effectiveness for booster doses and safety data regarding vaccine booster doses. And then this all led up to policy discussions around the use of booster doses that we'll hear more about today. And then in addition, the COVID-19 vaccines work group has discussed and reviewed a framework and the data needed for future doses of COVID-19 vaccines. Next slide, please. So here's the agenda for today. First, we'll hear from Dr. Link Gellis from the CDC, who will provide updates on vaccine effectiveness of COVID-19 booster doses. Following that presentation, we'll hear from Dr. Klein from Kaiser Permanente, Northern California, who will review safety updates of COVID-19 booster doses. Her presentation will be followed by one from Dr. Shimabukuro at the CDC, again regarding the safety of booster doses. Following that, we'll hear from Dr. Talbot, who's the chair of the Vaccine Safety Technical Subgroup, and she'll provide the vast assessment of the safety of COVID-19 booster doses. Following this, we'll have a break. Following the break, we'll hear from Dr. Oliver at the CDC, who will review updates to the ETR framework, which is focused on COVID-19 vaccine booster doses in adults age 50 years and older, as well as in immunocompromised individuals age 12 and older. Following Dr. Oliver's presentation, we'll hear from Dr. Hall from the CDC, who will review CDC guidance regarding second COVID-19 booster doses. Then we'll have discussion of the of those topics, followed by a public comment period. Next slide, please. And then after the break, we'll hear from Dr. Fink from the Food and Drug Administration, who will provide a summary of the FDA Advisory Committee meeting on future COVID-19 vaccine doses. And following this, we'll hear from Dr. Oliver from the CDC, who will discuss an additional details about the framework for future COVID-19 vaccine doses and next steps, and then we'll have additional time for discussion. Next slide, please. So I want to highlight the tremendous work of the COVID-19 vaccines work group. This includes work from ACIP members, ex-officio and government members, liaisons and consultants, and outstanding leadership of Dr. Sarah Oliver. Next slide. And then I also want to thank a number of CDC participants who make all of the work of the COVID-19 vaccines work group happen. So thanks to all the individuals listed here. Next slide, please. And that concludes my remarks. I'll turn it back to you, Dr. Lee.
Thank you, Dr. Daly. Now we'll move on to Dr. Ruth Wingelis to review data on vaccine effectiveness of the COVID-19 booster dose. And after her presentation, we will open it up for discussion.
All right, good morning. I'll be discussing today real-world vaccine effectiveness data during Omicron in adults. Next slide. The presentation is broken up into 3 sections by increasing severity of outcome under study, including infection, emergency department and urgent care visits, and hospitalization, including critical illness, with an overall summary at the end. Next slide. I'll begin with vaccine effectiveness data for infection with Omicron from both the US and the UK. Next slide. The Increasing Community Access to Testing, or ICAT platform, is national community-based drive-through testing data from pharmacies. Vaccine history and prior SARS-CoV-2 infection are self-reported at the time of test registration, and analyses use a test-negative design where cases are persons with at least one COVID-like symptom and a positive NAT test, and controls are symptomatic with a negative NAT test. For this analysis, models were adjusted for calendar day, race, ethnicity, gender, HHS region, and social vulnerability index. Any tests from individuals reporting a prior infection are excluded. This analysis covers tests conducted from December 26, 2021 through March 23, 2022. Next slide. Here we see results by booster regimen: 2 doses of J&J, 1 dose of J&J, and 1 dose of mRNA, and 3 doses of an mRNA vaccine by time since booster dose, 0 to 1 month and 2 to 4 months. We see the lowest VE estimates for individuals who received 2 doses of J&J, although there's no evidence of waning. Individuals who received at least 1 mRNA booster have significantly higher VE, with the highest VE for individuals who received 3 doses of an mRNA vaccine, 68% during the first month since the booster, and 63% for 2 to 4 months after the booster. Next slide. This slide from the UK shows VE for the BA1 and BA2 sublineages of Omicron. Though BA2 has not been prominent in the US long enough to estimate VE here, the UK has had higher rates of BA2 for a while and looked at VE by sublineage for Pfizer, Moderna, and AstraZeneca primary series with a Pfizer or Moderna boost. You can see here that VE was generally comparable for symptomatic infection after both 2 and 3 doses, with some evidence of waning for the booster dose. Next slide. To summarize for infection during Omicron, VE looks different for recipients of J&J versus individuals who received mRNA doses, with those receiving 2 doses of J&J having lower overall VE versus individuals receiving at least 1 mRNA dose. There was evidence of slight waning against infection for 3 mRNA doses by 2 to 4 months after the booster, although VE remains substantially higher than what we've shared previously for unboosted individuals. And finally, from the UK, we have data showing similar VE for BA1 and BA2. Next slide. Moving on now to VE for emergency department and urgent care visits in the US. Next slide. The VISION network is a multi-state network based on electronic healthcare records. Like ICAT, it uses a test-negative design with cases having CLI and a positive PCR and controls having CLI with a negative PCR. Delta versus Omicron was determined by the time when Omicron predominated in a study site, mid-December 2021 for all sites. VE is adjusted for propensity to be vaccinated weights, calendar time, region, local virus circulation, and age, with vaccination documented by electronic health records and state and city vaccine registries. Next slide. This is VE for mRNA schedules for emergency department and urgent care visits by time since last dose in adults 50 years of age and up, split by immunocompromised status, with immunocompromised in purple and non-immunocompromised in green. VE of 2 doses is generally similar for the two groups. However, for a third dose, VE appears higher and to wane less among non-immunocompromised individuals. Recall that for immunocompromised individuals, 3 doses are considered a primary series, so it's not surprising for this group to see the 3-dose VE here similar to the 2-dose VE in non-immunocompromised individuals. We did not have enough recipients of 4 doses to assess booster VE among immunocompromised individuals. Next slide. Now moving on to VE against hospitalization. Next slide. These are again estimates from the Vision Network, this time for hospitalization instead of emergency department urgent care visits. As expected, for a more severe outcome, we see generally higher VE for non-immunocompromised individuals. Confidence intervals for immunocompromised individuals are wider, with VE for both 2 and 3 doses generally lower compared to immunocompromised. VE for both immunocompromised and non-immunocompromised is higher for 3 doses compared to 2 doses, and waning of 3 doses for non-immunocompromised individuals is substantially less than for 2 doses. Next slide. Vision also looked at VE of the J&J vaccine during Omicron. Similar to the results shown previously for infection, VE of 2 doses of J&J or 1 dose of J&J and 1 mRNA was lower compared to 3 doses of mRNA. VE of any regimen, including a booster dose, was significantly higher compared to a single dose of J&J. Next slide. Finally, I'll share results from CDC's IV network, which is a VE platform enrolling hospitalized adults at 21 medical centers in 18 states. It uses a test-negative design with cases having CLI and a positive PCR and controls having CLI and a negative PCR. Next slide. Here we have results for 3 doses of an mRNA vaccine by immunocompromised status and time since 3rd dose, 7 to 120 days and greater than 120 days. Next slide. Similar to Vision, we see evidence of some waning among immunocompromised individuals, although confidence intervals for greater than 120 days are wide. We have less evidence for waning here among non-immunocompromised individuals. Next slide. Finally, IV also looked at VE for critical illness or in-hospital death in 2 recent publications. Here they found that VE of 2 doses for critical illness or death during Omicron was 79%, and VE for 3 doses was significantly higher, 94%, although with less follow-up time available. Next slide. Moving on now to summarize. Next slide. Here we see data summarized, including 2-dose VE in green and 3-dose VE in magenta, with increasing severity shown on the left-hand side of the slide as you go down. As we've seen previously with Delta, where we have higher vaccine effectiveness for more severe outcomes. These data also show the clear benefit of a 3rd dose over a 2nd dose during Omicron, and a highest VE, 94%, for 3 doses for critical illness and death out to a median of 60 days of follow-up. And we see VE remaining high versus hospitalization among non-immunocompromised individuals for 4 to 6 months after the booster dose. Next slide. In summary, we've previously seen limited protection and faster waning for 2 doses of mRNA vaccines against infection. Here we showed higher VE and less waning for 3 doses of mRNA vaccines for all outcomes among non-immunocompromised individuals. Although we could not estimate VE for all outcomes among immunocompromised individuals, we saw a similar pattern as with non-immunocompromised, higher VE for worse outcomes, although immunocompromised individuals had lower VE than non-immunocompromised, leading to the earlier additional dose recommendation. Next slide. I'd like to thank the individuals shown here who contributed data to the presentation, and I'm happy to take questions. Thank you.
Thank you. This presentation is now open for questions. And while we're waiting for hands to be raised, first I just want to acknowledge that it is clear that the vaccines and in particular, the first booster dose are effective against severe outcomes such as critical illness, death, hospitalizations, and emergency department visits. So I do think that that evidence looks very compelling. I'm going to ask two questions that are more forward-looking, but related to the data you showed. One is it possible for us to begin to look at the intervals between dose 1 and dose 2 to, again, see if there is a more durable immune response similar to what we've seen in other countries, recognizing we may not have a lot of variability on that here, but we still have, an opportunity with pediatric vaccines to consider that. And then I'll have a second comment or question for you.
Sure. So we have tried to look at interval between first and second dose among adults in a number of our platforms, and there just wasn't a lot of variability. So at most, we had Pfizer recipients getting the dose at 3, 4, and a few at 5 weeks, but very few longer than that, and a similar pattern for Moderna. So we have not had enough power to look at the sort of 6, 7, 8 week intervals that we're really interested in. We do plan to look at that, though, for the younger populations, and it's possible that there will be more variability, although with vaccine rates and coverage just generally being lower in that population, we're not sure we'll have enough power for that either, but we do continue to review that.
Thank you. Yes, we might have limited power, but it's also an opportunity for us to think about, how we immunize the younger population. The second, comment or question that I realize is probably not answerable right now, but I'll just highlight the data indicate that individuals who receive a J&J primary series, so a single dose, followed by an mRNA booster, perhaps seem to have slightly lower levels of protection than those who receive 3 mRNA vaccines. The EUA right now limits our ability to be able to provide access to an additional booster dose to that population. Perhaps this is not specifically for CDC. I'm not sure, actually, Dr. Fink, if you can respond to this or not, but it does seem like, given that we are trying to provide access to second booster doses, there might be reasonable consideration for that population to also provide access. Whether or not it should be recommended is a different story, but it does seem like we're in this position of ensuring that there will be the ability to receive a vaccine if it should be desired or needed.
Hi, this is Jordan Fink. So the authorizations for the mRNA vaccines from the end of March include use of either mRNA vaccine as a second booster dose following any previous primary series and first booster regimen. Does that answer your question?
Yes, I'm thinking about, and I don't know what slide it is, but I don't know if Dr. Linkellis, you can go to the slide comparing the J&J vaccine recipients with the various booster regimens. Thank you. Yes. Yeah. Go ahead.
No, this is Dr. Oliver. Was also just going to provide, and so we can let Dr. Linkellis kind of walk us through this slide again, but it was also in review of the language that was in the EUI, it was kind of the totality of the data for this, so no kind of one singular study, but looking at the antibody levels that were seen from the NIH mix and match study, as well as kind of the VE against infection, against urgent care visits, as well as VE against hospitalizations. So it was kind of the totality of the data that was reviewed for the language in the EUI. We can continue to assess, obviously, as we get additional data. And then Dr. Linkellis, if you want to say anything about this slide.
No, I don't think I have anything to add.
Thank you. we'll just, point that out that hopefully we can continue to look at that. And I recognize this is such a complex set of circumstances and not a typical BLA, but it would still be wonderful to actually at least provide access. Dr. Duchin.
Thank you. A question for Dr. Link-Ellis. Just if you could briefly help us understand if there are any key limitations in the two data systems that you discussed that would potentially impact the findings. I know you mentioned quickly that I think it was ICAT was propensity adjusted for propensity to be vaccinated, and I'm just wondering if there are any other limitations that could have affected the findings that we should be aware of for either system.
Sure. I think for ICAT, which is the National Pharmacy Testing Data looking at infection, testing practices are always going to be a limitation. It's not systematic testing, it's individuals who present for testing at retail pharmacies. And so certainly with the rise of home rapid antigen testing, testing practices have changed. That's something that the study staff continues to monitor in that system and has done some work looking at type of testing, so rapid PCR versus a lab-based PCR. They have confined their analysis to symptomatic individuals, hoping to mitigate a little bit of that bias, but I think it's likely that that's something that continues to affect the estimates and probably affects the estimates a little bit differently over time and probably differently for different age groups. So that's ICAT for infection. On the hospitalization side, I think testing practices are less likely to result in bias. Both of those platforms are looking at individuals that are hospitalized. They use a COVID-like illness case definition, and all individuals in those hospitals all individuals hospitalized in those hospitals are tested, regardless of whether they're hospitalized for COVID-like illness. So I don't think we would have the testing biases issues there. A couple of things that might affect the estimates for hospitalization. One is prior infection. They do control for prior infection or exclude individuals with prior infection documented in the medical record. However, just because not everyone is symptomatic, not everyone has a prior infection documented, it's possible that they've missed individuals with prior infection. So I think that would be the main potential bias there for hospitalization. And again, they do look at a COVID-like illness definition to try to mitigate some of the testing issues. I think that would probably be the major one.
Thank you.
Thank you. Dr. Daly?
Yeah, thanks so much. Dr. Link-Ellis, this question is around our ability to assess waning VE after a first booster dose. And so could you just remind us how, in the platforms that you presented today, how long after receipt of first booster for the immunocompetent, and then how long after first booster for the immunocompromised? And I guess another way to ask the question is kind of when will we have sufficient data on 6, 7, 8 months after that first booster dose to see what the VE is in these different populations? Thank you.
Sure. So I think, it's all going to come down to power. We had, obviously, with the Omicron surge, quite a lot of case accrual in these systems in January, February, and early March. With cases dropping off substantially since then, I think it will take a lot longer to accrue enough cases to look at sort of the tail end. We are obviously continuing to monitor as cases come in, and if BA2 results in a surge, we'll have more ability to look in the next couple of months. But I would expect that by June or July, we should have additional estimates available.
Thank you. Dr. Bell.
Thank you. Just another question similar to Dr. Daly's, but with a slightly different issue. The question has to do with your power to stratify according to age. As we all know, there's more concern for adverse outcomes the older one gets. There's also differences in response to vaccination. So I'm sort of asking a parallel question to Dr. Daly's about when you think you might be able to provide VE data following one booster dose stratified by age group.
Sure. So the estimates shared from Vision in this presentation are for individuals 50 years of age and up, and we did that because of the current policy recommendation for the second booster. We did look at individuals under 50 and looked by immunocompromised status, and just at that point, we're getting into very small numbers and unstable estimates. But again, I think over the next couple of months, especially depending on what happens with BA2, we should have more cases and we'll be able to provide additional estimates in the next couple of months.
Thank you. Are there any other questions for Dr. Link-Ellis? I don't see any additional hands raised. We can always come back to this later. With that, I'd like to move towards the updates on safety of COVID-19 booster doses. And thank you, Dr. Gillis, for your presentation as always. I believe we'll have Dr. Nikki Klein presenting first from Kaiser Permanente, Northern California. Dr. Klein, as soon as your slides are up, you can please go ahead and proceed.
Good morning. Thank you for the opportunity to present some of our recent updates and safety updates. Next slide, please. So this first part of the presentation, I will be presenting the safety surveillance of the first booster doses and the vaccine safety data link. Next slide, please. So as many of you are aware, the Vaccine Safety Data Link, or VSD, was established in 1990. It's a collaborative project between CDC and the 9 integrated healthcare organizations you see here on the map, and it includes approximately 12 million individuals across all sites within the United States. Next slide. So this here is the data on the VSD first boosters by primary series vaccination, and this is data through April 9th of this year, 2022. Now, to orient you to the slide, on the left-hand columns, you can see the 3 vaccines listed as these are the primary series that the individuals received, focusing, not spending too much time on Janssen, mostly on the Moderna and Pfizer on the primary series. Now, in the middle column, you can see the title booster type, and that is the booster dose that was received after the primary series shown on the left. Focusing on the middle, you can see that from the following the Moderna primary series, 1.76 million individuals received Moderna boosters, and that's 92% of those individuals received Moderna, followed by Moderna boosters. Similarly, for those individuals who received Pfizer's primary series, looking in the center column, you can see that those who received Pfizer represented 93% of those people, and that's over 2.4 million booster doses. So focusing most of today's updates on the Moderna and Pfizer individuals, because almost all individuals who received the same booster from what their primary series was. And finally, a last piece to focus on, the VSD does include booster doses on 4.77 million doses. So that's the population we are discussing today. Next slide. So here's a brief look at the demographics of the VSD first booster doses. And the main things to focus, this is a busy slide, but that more booster doses were given to females than males, and that most of the booster doses were given to individuals 18 to 49-year-olds. Very few were given in the younger than 18 population, and that smaller amounts in the older populations. Now, in addition, that more of the booster doses were given to individuals who with the race ethnicity of white, non-Hispanic, followed by Hispanic, Latino, and then also Asian race. Next slide. So for the VSD rapid cycle analysis, or RCA, for boosters, a brief description of what we did for the analysis. And what we've been doing is pre-specified surveillance outcomes were assessed during weekly sequential monitoring after the first COVID-19 booster vaccination. We have done some very well-adjusted analysis, which I will be describing in a minute, a little more detail, but it's written out here in words as well. But the weekly sequential analyses will continue through 2022, and we are using a one-sided p-value as a threshold for safety signaling of 0.01. In addition, due to the association of myocarditis pericarditis with primary mRNA vaccination, myocarditis and pericarditis cases after the first booster were also chart reviewed and adjudicated using the CDC case definition. Now I'll be discussing the analysis just in a little more detail in the next slide, please. So this is the analysis that we've been using for what we call the RCA for the first booster dose. And this is analogous to what we did for the primary series, which we use what we call vaccinated concurrent comparators. But in this case, our concurrent comparators are boosted individuals. That is people who received the primary series and also received the booster dose. We're comparing boosters to boosters. And we're comparing individuals who are in the risk interval, 1 to 21 days after their vaccination, with similar individuals who are in their comparison interval, 22 to 42 days post-vaccination. And we're comparing events on the same day. So an individual who had, for example, myocarditis on June 3rd, following a booster dose on May 30th, is compared to an individual who on June 30th is in a comparison interval following their booster. And individuals who are comparators were compared, but we compared the same individuals in the sense that they had in the same age group, of the same sex, race, ethnicity at the same VSD site. That is, all analyses are very well adjusted for calendar day, age, sex, race, and at the same VSD site. Next slide. So this here is a overall summary of the signals for all the pre-specified outcomes in the 21-day risk interval through April 12, 2022. Now, on the left-hand column, you can see all the pre-specified outcomes that we are sequentially monitoring. These represent serious outcomes and analogous to the outcomes that we are following for the primary series. Again, these are only the booster doses. And on the top rows, you can see that the primary series that individuals received, and then the first booster product that they received in the second row. Now, what you can see here when we look at whether any of these analyses have signaled, the only one that clearly that you can see is myocarditis and pericarditis, and that is for individuals who received either mRNA vaccine for the primary series as well as for the signal, excuse me. So for my presentation, I'll be focusing a little more on this signal for the myocarditis and pericarditis. Next slide. And here I'll be discussing the preliminary chart review analysis. Next slide. So the myocarditis and pericarditis, you have seen a version of this before, but these are the electronic case identification codes that we're using for ICD-10 codes. Just as a reminder, the first four are the codes that we use for the primary series, and we have added the last two codes for case identification for these booster analysis. And the star represents that we include all subcodes within those ICD-10 codes. So next slide. So the summary for our myocarditis and pericarditis booster chart review summary. So we are chart reviewing all electronically identified cases that occur up to 98 days post-vaccination, and we are chart reviewing all ages. So we have today completed chart reviews for 271 cases through March, and we still have 25 potential cases pending. Cases have all been adjudicated, and the adjudicators verified 139 of the 271, and that's 51% as myocarditis and pericarditis. Now, what we have noted is that there's a difference between adjudication and verification depending on age. For those who are 12 to 39-year-olds, 53 to 68, or 78% were adjudicated. The adjudicators verified them as cases, versus the individuals who are 40 plus years and older, as only 42% have been adjudicators verified them. So next slide. A little more descriptive on these differences. So these are the same cases I just mentioned to you in the different age groups. When we look at the differences between the different age groups, You can see that in the male sex, like we saw for the primary analysis, 72% were males. Majority were also males of 40 plus years, but less so at 59%. There was few cases that we were aware of that had a history of COVID more than 30 days prior to their diagnosis. But some other differences is the median age. It's not surprising. In the younger age group is 25 years. However, the median age for the older individuals over the age of 40 was 68.5 years. The median time to vaccination also differed in that there are 4 days for the younger group and then 29.5 days for the over 40 group. Now, the biggest difference, however, is the diagnosis itself. In the 12 to 39-year-olds, again, similar to what we saw for the primary analysis, the primary doses, that most cases, in this case, 78% of the cases were adjudicated as myopericarditis or myocarditis, with just under a quarter being pericarditis. In contrast, those in the 40-plus-year-olds, 2/3 were adjudicated as pericarditis, with a smaller proportion as myocarditis or myopericarditis. So for this reason, we have analyzed these groups separately in terms of different age groups. Next slide. Now, when we look at the timing of onset of the first booster dose, now this is the 53 verified myocarditis and pericarditis cases in 12 to 39-year-olds. What you can see with the days since first booster dose on the x-axis and case counts on the left, that the cases, similar to what we saw with the primary dose, is that the cases are clustering within the first 5 days after vaccination quite dramatically. In contrast, next slide. When we look at the cases, the timing of onset after the first booster dose of the 86 verified cases in 40-plus-year-olds, you can see that while there appears to be some mild clustering in the first 3 weeks after vaccination, we also see a lot of cases that are spread throughout the post-vaccination time period we're identifying cases. Next slide. So this is the analysis, which we, again, going back to the graph I showed you what the analytic framework is, these are the vaccinated concurrent comparators using the boosted comparators. And these are verified myocarditis and pericarditis in the 0 to 7 day risk interval. And again, comparing events on the same calendar day among primary series and boosted comparators. What you can see here among those who are aged 12 to 39, that we have an adjusted rate ratio for either vaccine as elevated nearly 4.9, with a confidence interval range 2.2 to 11.3, and it's statistically significant. And there's about 20.3 events per million. That is the rate. Next slide. However, when we compare the same, and this is analogous, on the top rows are now the analogous analysis to primary dose that we did. And what we can see here is that the rate ratio for the primary dose for the same analysis was much higher than we're seeing with the first booster dose. And you can see the confidence intervals as well as the rate per million doses. So what we can see here is that for the 12 to 39-year-olds, the myocarditis and pericarditis events, the rate was elevated, but certainly not higher than what we saw with the primary series, and perhaps maybe a little bit lower. Next slide. Now, this is now looking at the same analysis in 0 to 7 day risk interval, looking at those individuals over the age of 40, and those are the bottom 3 rows. So what we can see here is the adjusted rate ratio is elevated also for those over 40 and who received either vaccine, although it doesn't quite meet statistical significance, as you can see by the confidence intervals and p-values. However, I just showed you that the cases within the over 40 are not just occurring in the 0 to 7 day risk interval. So next slide. We have done the similar analysis in the 0 to 21 day risk interval. Again, this is the same vaccinated concurrent comparator analysis. This is focusing on just the 12 to 39-year-olds. And you can see that there's, again, an elevated rate ratio, but somewhat less so than the 0 to 7 days, and the confidence intervals are not statistically significant. Next slide. Now, when we look at the over 40, you can see that the adjusted rate ratio is just under 2, and as well as for the Pfizer only vaccine. And you can see that the confidence intervals are now just over one, lower bound is just over one and just needs statistical significance, as you can see there, as well as the events per million with 11 events per million doses. Next slide. To summarize these preliminary findings of the RCA monitoring for the first boosters. In weekly surveillance, the only safety signal has been for myocarditis, pericarditis in the 21 days after first booster dose. No other safety signals in weekly monitoring of pre-specified outcomes. Myocarditis, pericarditis differ between persons aged 12 to 39 and 40 plus years. For 12 to 39-year-olds, it's mostly myocarditis and myopericarditis with the onset less than 7 days after the first booster. For 40 plus years, it was mostly pericarditis, and all cases were spread out in the 3 weeks after the first booster. For persons aged 12 to 39 years, rate ratios for myocarditis and pericarditis 0 to 7 days after the first booster dose were elevated, but the rate per million first booster doses administered was not higher than after the primary series dose 2 mRNA COVID-19 vaccination. For persons aged 40 years and over, rate ratios for myocarditis, pericarditis were elevated, but less so in the 0 to 7 and 0 to 21 days after the first booster dose compared with persons aged 12 to 39 years. And of course, surveillance is ongoing. Next slide.
Thanks, Dr. Klein. This is Tom Shimabukuro, and I'm going to be covering Vares and V-safe monitoring. Next slide. So I'll start off with the VAERS, and I'm going to move through the background on these slides pretty quickly because I know you're familiar with the background, but VAERS is our early warning system for vaccine safety. Next slide. And it's subject to the strengths and limitations of passive surveillance in general. Next slide. So this is a summary table of U.S. reports to VAERS following the first booster mRNA COVID-19 vaccination, and all these data are for first booster dose. After just over 93 million first boosters administered, there were just over 52,000 total reports. The median age in these case reports was 53 years. It was about 1/3 male, 2/3 female, which is consistent with primary series reports, and 90% non-serious, which is also consistent. Next slide. This is the breakdown by race and ethnicity. Next slide. So these are the most frequently reported non-serious adverse events following first booster dose. On the left-hand side, it's all reports to include non-clinical outcomes that you see highlighted there in blue, and those are associated with vaccination errors. And then on the right-hand side are the most commonly reported events when we exclude the non-clinical outcomes. And systemic and local reactions are the most commonly reported non-serious adverse events. Next slide. This slide is the similar slide, but for serious adverse events. And again, on the left-hand side, it's all reports, and then the right-hand side is when the non-clinical outcomes are removed. And these adverse events do represent mandatory reporting requirements for selected adverse events under the EUA, namely COVID disease and other serious outcomes. Next slide. So moving now into reports of myocarditis and pericarditis following first booster dose. And you see here that we have 110 myocarditis reports and 38 pericarditis reports. The median age for myocarditis reports is lower than pericarditis, 23 years versus 46 years. The median time to symptom onset is similar, but the interquartile range is more spread out for pericarditis. And then the myocarditis reports, similar to primary series, are predominantly male, 81% to 19%, and then for pericarditis, it's roughly even, 47% to 53%. Next slide. So this graph and the next several graphs shows myocarditis or pericarditis reports following first booster dose among males, and these are case reports with onset within 0 to 7 days, and this is by age group. The myocarditis reports are in blue, the pericarditis reports are in orange, and they're shaded for Pfizer and Moderna. Next slide. So what I've highlighted here is that most myocarditis reports are among persons aged 12 to 29 years. Next slide. Pericarditis reports appear to be fairly distributed fairly evenly among the age groups. Next slide. So this is a similar graph, but for females. I think the take home here is that there are fewer reports among females of either condition, and both myocarditis and pericarditis reports are distributed fairly evenly among age groups. Next slide. So I'm showing this table here of reporting rates of myocarditis, and that's per million doses administered among males following first mRNA COVID-19 booster dose vaccination in the 0 to 7 day risk interval. There's been 41.6 million first boosters administered in males. The reporting rates exceed background incidence in the ages 12 to 29 years, and just want to highlight that that Moderna is only authorized in 18 and over. That's why you see the non-applicables there. The reporting rates are highest in males aged 16 to 17 years, followed by 12 to 15 years. But by the time you get to age 30 and above, the reporting rates are within background. And I do have a side-by-side comparison of what this looks like for primary series versus booster series and extra slides, which I can certainly show you during the discussion period if you want to see that. Next slide. So these are the clinical outcomes of myocarditis and pericarditis following booster vaccination. Again, after 93 million total booster doses administered, 82% of the myocarditis cases were hospitalized versus 39% of the pericarditis cases. All were discharged. There were known outcomes for most of the reports, both for myocarditis and pericarditis. For myocarditis, 59% had recovered from symptoms at last follow-up, and for pericarditis, it was 71%. Next slide. Moving on to V-safe, which is our text-based active monitoring system. Next slide. I know you're familiar with V-safe, so we'll proceed to the next slide. So these are patterns of vaccination for the roughly 729,000 V-safe participants aged 18 and older who reported a booster dose. Showing this this table mainly to demonstrate that most individuals stay within their product. So what this table is showing is that for individuals that had a Moderna primary series, 94% of them received a Moderna booster. That's the upper left-hand corner there in blue. And likewise for Pfizer, 95% of the Pfizer primary received a Pfizer booster. That's a little bit different for Janssen. Our focus is going to be on the mRNA vaccines for the rest of the V-safe data. Next slide. Here's the demographic summary of these individuals 18 and over. I do have Pfizer data for 12 to 17, and that's 3,694 individuals in that age group, 12 to 17. Next slide. So these are reactions and health impact events reported by participants 18 and over in the 0 to 7 days after homologous Pfizer vaccination by dose. And you can see here that generally local reactogenicity, systemic reactogenicity, and health impact events are reported less frequently, slightly less frequently after booster dose compared to dose 2. Next slide. This is the same graph, but it's for individuals 12 to 17 years of age after homologous Pfizer vaccination by dose. So injection site reactions and systemic reactions are about even, about the same for booster dose compared to dose 2. And then health impact events are reported more frequently for booster dose compared to dose 2. But if you just note this unable to work or attend school, what we think that is driving that finding for health impacts, and that's largely driven by what was happening with school at the time of dose 2 compared to boosters. So for dose 2, there was a lot of virtual learning. For boosters, it was mostly in-person learning. So the physically not being able to attend school, we think, is more likely to be reported versus that happening in a virtual environment. So it's the same question, but it probably is really asking a different question based on where we were with the pandemic. Next slide. This is the same graph, but for Moderna, homologous Moderna vaccination. And similar to what we see for Pfizer in this age group, there appears to be slightly less reporting of reactogenicity and health impacts following booster dose compared to dose 2 for Moderna, although the differences appear to be a little bit more compared to Pfizer. Next slide. Next slide. So in summary, Dr. Klein has already presented the summary for the VSD. This is here for completeness, for reference, so we'll proceed to the next slide. So for VAERS monitoring, and this is after 93 million first mRNA booster doses, local and systemic reactions are most commonly reported following first booster dose. There are 110 verified reports of myocarditis and 38 of pericarditis. The myocarditis reporting rates were highest among young males aged 12 to 29. Reporting rates for persons in this age group exceeded background, but were lower compared to post-dose 2 rates with primary series. Pericarditis reports were relatively rare and distributed evenly among males and females among the varied age groups. More myocarditis than pericarditis case patients were hospitalized. Most hospitalized patients recovered from symptoms at the time of follow-up. And then for V-safe monitoring, there were no unusual or unexpected findings or new safety concerns identified. Next slide. Active surveillance in VSD and passive surveillance in VAERS suggest an increased risk of myocarditis and pericarditis following first booster dose. For myocarditis, the findings are consistent with those observed with primary series vaccination, but the risk appears to be lower following the first booster dose compared to dose 2 of the primary series. Risk of myocarditis is highest in younger males with onset clustering within 0 to 7 days. Pericarditis is less common, more evenly distributed between males and females, and more evenly distributed across age groups. I'll just mention, though, we do say the risk appears to be lower. We do recognize that it's possible that individuals who had myocarditis after primary series may select out of getting a booster dose, and that may be impacting the findings. Local and systemic reactogenicity and health impacts appear to be similar or attenuated for first booster dose compared to dose 2 of the primary series. And finally, monitoring is ongoing. Next slide. I'd like to acknowledge the following groups and individuals for their contributions. Next slide. And that concludes my presentation. Thank you.
Thank you so much, Dr. Klein and Dr. Shimabukuro. I think right now we will open this presentation for clarifying questions. Dr. Lair.
Thank you both for a lovely presentation. I've got a question for each of you. For Dr. Klein, for the older group with the myocarditis, did it exceed the background rate or was it close to the background rate? It seemed odd that 68-year-olds were getting myocarditis and pericarditis and it didn't seem to cluster at all.
So that's a great question. We haven't yet actually done the analysis separating out myocarditis from the pericarditis cases. So we are working on those questions right now.
Thank you. And for Dr. Shimabukuro, Could you comment a little bit more on the possibility that the lower rate of myocarditis and pericarditis after the booster dose is because of self-selection, that possibly the people who got the myocarditis earlier with the first 2 doses simply didn't get the booster dose? Would that, I'm just curious, how much of an effect might that be? Thank you.
We just acknowledge that individuals who got myocarditis after a primary series dose may select out of getting a booster dose, and that may impact our surveillance findings. I don't know how much that may impact the surveillance findings, but I think it's something to consider when you interpret the data.
Thank you. Dr. Sanchez.
Thank you for that presentation, for both presentations. And certainly myocarditis remains a concern in the young males. But my question was, did you see, or were you able to see a difference between the Pfizer versus the Moderna? It seemed like in the younger age groups, there was a suggestion that maybe the Moderna was a little bit less, but the cases are few. But I think that's a little bit different than previously. Or were you able to make any difference between the two?
I'll assume that is directed at me, I believe.
Either one.
Yeah. So I could just tell you from our booster analysis, when we compared it to a primary series analysis, we had proportionately more younger individuals in our analyses for our booster than in our primary series. So we had proportionally more Pfizer than in Moderna. That makes sense. We have more young people in our primary series analysis than we had in our booster analysis, so that's skewed a little bit older population. But we haven't seen any suggestion necessarily for the 12 to 39-year-olds between the two vaccines to date.
So you were not able to detect a difference between the myocarditis risk among those who receive Pfizer versus Moderna?
Well, our analysis, we do have on the slide that was up there, if you want to show that again, we do have the rate ratios by vaccine product. You can see that, yeah. But we haven't done a direct comparison of those two vaccines.
This is Dr. Shimabukuro. If you go to slide 62, I mean, this may provide a decent visual. So what you're seeing is dose 2 reporting rates on the left-hand side and the booster reporting rates on the right-hand side. What is on the right-hand side is what I presented today. So if you look on the left-hand side, you can see that there's a general trend of slightly higher reporting rates for Moderna compared to Pfizer. And then when you look on the booster, you can't compare with the youngest age groups, and in the 18 to 24, there's a difference in reporting rates there, but these are pretty small numbers, and then once you get above that age, they look pretty similar. So I think I would agree that we probably don't have sufficient data right now to draw conclusions about differential risk for booster dose, but we continue to monitor.
Thank you. Dr. Sanchez, anything else?
Sorry, no, thank you.
Thank you. Dr. Daly.
I think this question is for Dr. Shimabukuro. Can you talk just qualitatively about the severity of the myocarditis cases that were reported to VAERS, and then just compare that to the severity of myocarditis cases reported after second dose? Thank you.
We have, from the VAERS reports, from the individual VAERS reports and from the medical records reviews that we've done and from provider interviews, they appear to be similar for the dose 2 cases. Post-dose 2 cases appear to similar for the post-booster cases, and then they tend to be clinically mild, and individuals have fully recovered by discharge or by the time we follow up or are improving. So I think that they are basically similar to what we observed for vaccine-associated myocarditis for the primary series.
And if I could just comment as well, I think I didn't mention this, but we have also noted that in our chart reviews for the younger individuals, the myocarditis cases look very much like the cases that we saw for the primary series as well in terms of clinical outcomes.
Great, thank you for that.
Dr. Cotton.
Thank you for the excellent presentations. I was wondering if you had information on immunocompromised patients and their overall risk of these serious adverse events.
I can say for VAERS, we do not monitor specifically for immunocompromised persons as a special group. I will say in general, based on what we know about inactivated vaccines, that immunocompromised persons tend to have lower reactogenicity and are not at increased risk for serious adverse events.
Thank you.
Thank you. Excellent question. Dr. Freihofer.
Yes, Sandra Freihofer, American Medical Association, speaking as a practicing physician. Can we go to Dr. Klein's slide 15, please? This is a sort of a follow-up question to the earlier question. So if you look at Pfizer and Moderna and look at the two adjusted rate ratios, the Moderna is lower. Is that because there were fewer patients that could get Moderna because of the age appropriateness of the booster? So most of the more were getting Pfizer. Does that explain those numbers? Because that's sort of the difference, I think, that one of the previous speakers who asked the question alluded to.
Right. So I think right now it's true that the 12 to 17-year-olds cannot get Moderna booster. That being said, we have not had very many. I don't actually change it, but if you yourself look at the age distribution, we have very few booster doses given to individuals 12 to 17-year-olds at all in general. I think I don't have an answer in terms of why there's fewer cases, but what I think probably what's more important to focus in on is that the adjusted rate ratios are actually not different when you look at the confidence in the two-sided p-values, as well as the events per million. If you look at the rates of myocarditis in these two groups, they really do not differ. 17 and 21 and these analyses are not different. So
thank you. That's very helpful. Thank you.
Are there any additional questions before I move on to Dr. Talbot's summary? I have one just quick question, Dr. Klein. If you go to slide 14, it makes intuitive sense to me. Well, first of all, it looks like those could be potentially, background rates that are happening. But I can understand when the risk interval is compared to the control interval is, up to 21 days and then 22 to 42 days, how there might be an elevated rate ratio. Will you look into whether or not other comparator groups might actually be helpful, either different time intervals and or individuals who did not receive booster doses? Because I'm just wondering if in the context of COVID being endemic / in sort of these waves, whether or not this could be related to what we're just seeing in the general population.
Right. So yeah, that's a great question. And the short answer to your question is yes. The first one being that we have always been doing and pre-specified in a protocol, but we have not focused in on it for a variety of reasons. But we are doing the 42-day analysis compared to the 43 to 84 days. But we have to wait for that enough time to pass for that analysis to be eligible to be done. And we're just now reaching the time point where we could do those analyses soon. So we will be doing a longer interval for 42 days post-vaccination. And we do also, in the background, always do unvaccinated comparators as our analysis, but we haven't featured them again because we've always felt that the vaccinated concurrent comparators, whether it's the primary series or these boosted comparators, are really the most appropriate comparators for a variety of reasons to prevent bias. But yes, we are doing both of those extra analyses.
Thank you, Dr. Klein. Are there any additional questions? I don't see any hands raised, so I think we can move on to Dr. Kip Talbot, who will be providing an assessment from the Vaccine Safety Technical Work Group and an overview of the interpretation of the data that has been presented to date. So Dr. Talbot.
Thank you. I'm presenting the COVID-19 Vaccine Safety Technical Work Group assessment of booster doses on behalf of myself and Dr. Robert Hopkins, who is currently the NVAC chair and the co-chair for next slide. So as a reminder, the objectives of VAST include review, evaluate, and interpret post-authorization approval COVID-19 vaccination safety data. We serve as a central hub for technical subject matter expertise from federal agencies conducting post-authorization/approval safety monitoring. We give advice on analyses, interpretation, and presentation of vaccine safety data, and provide updates to the ACIP COVID-19 Vaccines Work Group and the entire ACIP on COVID-19 vaccine safety. To put this in perspective, we have had 55 meetings to review safety data since December 21st, 2020. Next slide. This is a graphic depicting the different sources and types of vaccine safety data that we receive. You'll notice on the left was active surveillance, passive surveillance, and case consults, which gave us data early on and gives us early data on changes to any of the vaccine recommendations. And these include V-safe, VAERS, the VA, and CISA. Moving to the large link databases, which give us information as more data is known. And this includes the Vaccine Safety Data Link, for which you just heard data from, the VA EHR and Data Warehouse, and the FDA Vaccine Surveillance Program with their federal partners and BEST initiatives. Next slide, please. When it comes to vaccine safety after a booster dose, ACIP has had 4 presentations from VAST, including September 13th, 2021, October, November, December. Sorry, let me back that up. VAST has done reviews on multiple sources of data that have been presented to ACIP, and that has included September 22nd, October 21st, and November 19th in 2021. And our last presentation included data from V-safe, VAERS, and the Israeli data on January 4th, and this included data from 12 to 15 years of age. Today will be our 5th presentation on booster dose safety, and this will include data from VSD and VAERS, Department of Veteran Affairs, VSD, VAERS, and V-safe. Next slide. So the safety of the first messenger RNA COVID-19 booster dose, V-safe, is adults greater than 18 years of age. There was injection site systemic reactions, but they were less frequent following booster than following the primary 2 doses. For those ages 12 to 17, the frequency of reactions were equal or slightly higher following booster than following the primary dose 2. The VAERS data showed myocarditis rates highest among males 12 to 29 years of age, and the rates were higher than background, but lower than the primary dose when given the booster. Pericarditis reported similarly by sex and age group, and low case counts complicate estimation of rate. Next slide. Data from the Vaccine Safety Data Link, rapid cycle analyses, which has been presented, but in summary, the only safety signal seen was the myocarditis, pericarditis, and the 21 days after the first booster dose. In 12 to 39 years of age, it's mostly myocarditis and myopericarditis. The onset is rapid within 7 days after vaccination, and the rate per 1 million first booster doses is not higher than after the primary series dose, and that would be the rate of myocarditis. In those over 40 years of age, it's mostly pericarditis, and the onset is up to 3 weeks after vaccination. Data from the Department of Veterans Affairs shows no safety signals observed for messenger RNA vaccines, in a 21-day window. Chart review confirmed 15 of 40 pericarditis reports after booster dose, 10 of which were pericarditis, 5 myocarditis, and 14 of 15 in persons age greater than 40 years of age. Next slide. So the VAS overall assessment on COVID vaccine first booster dose safety. VAS has provided assessments on booster dose safety at 4, now 5 ACIP meetings. Today's assessment included data from VSD as well as V-safe, Vares, and VA. Reactogenicity is similar to or lower than that seen after the primary series. Myocarditis risk appears lower than after the primary dose 2. Further work and analyses are needed to understand pericarditis risk. While data do not suggest safety concerns beyond those previously identified, VAS will carefully monitor data on myocarditis and pericarditis after booster doses. Next slide. VAS will continue to review further safety regarding booster doses as data become available. We will collaborate with global vaccine safety colleagues on key issues, and will continue to provide updates to the ACIP work group and the ACIP at future meetings. Next slide. I want to thank all that participate in the VAS committee, especially our CDC colleagues and our ex-officio, including NIH, FDA, CMS, Indian Health Service, VA, Department of Defense. Thank you very much.
Thank you, Dr. Talbot. This presentation is open for questions. I don't see any hands raised from our members. We'll go to our liaison. So Dr. Hogue.
Thank you, Dr. Lee, and thanks to everybody for all of the presentations on safety. I know this has been discussed through all of your presentations, but I just want to ask the question once again so that I'm clear on it. It appears through all of the safety presentations that there may be some increased risk following booster doses of myocarditis and pericarditis in older adults. After the primary series, it was very clearly that younger adults was where the risk lay, but it appears to be a little less clear with booster doses in terms of the older adults. And I just wonder if Dr. Talbot or any of the other safety presentation presenters would like to just comment on that. It doesn't seem like there's anything statistically significant, but maybe some trends, and I'd just like to make sure I'm clear on that.
Absolutely, and I think we feel the same way. We ask many of the same questions. So it looks like there may be an increase of pericarditis in those over 40 years of age with the booster dose, much less so myocarditis, mainly pericarditis. It is definitely spread out over the 3 weeks, so it's less syndromic as the myocarditis is in a younger adult. When they review the cases, less of them appear to be verified. And so I think there's still a lot left to be known. We are also not clear on who's receiving the booster doses and if they're different than those who are not. So I think this is an area where we will very carefully review data and continue to ask for more data. I think that's it.
Thank you.
Thank you. Dr. Cotton.
So I was wondering, we cut the booster dose of the Moderna vaccine in half from the 100 down to 50. And I was wondering, I don't think in any of this data we have any information about the impact of that dose reduction. Is that correct?
I don't think we've specifically looked at safety data when it comes to half the dose. I think it's difficult in light of the fact that it's a third dose and we're still looking at it as just a third dose.
Yeah, I don't know.
If I could comment on that, sorry.
That'd be great. Thank you, Nikki.
So just for the VSD, the case definition for our booster doses, we did specifically try and eliminate individuals who are receiving a third dose for being immunocompromised, which would be a higher dose, versus those who received her booster dose, using the time frames in terms of when someone would be considered that dose as being a booster dose for the Moderna. So while we haven't done those specific comparisons, our analysis, we believe, is mainly just the first booster doses versus a third dose for immunocompromised individuals.
So, okay, so then if you didn't exclude them, and I understand that they're immunocompromised, did you see a significant difference? I sort of know that you're kind of pulling apples and oranges, but I'd just be interested to know if decreasing the dose from 100 down to 50 actually provided fewer SAEs.
Yeah, no, it's a great question. We haven't looked at that. I mean, we're really focusing what we think our booster dose is, but we haven't actually looked at the dose differences for the Moderna.
Okay. I can appreciate it's better science to probably eliminate them because it is different populations, but nonetheless, I was interested in just knowing if that approach worked to reduce the booster dose. Thanks.
This is Tom. I'll just mention that in Vares and in V-safe, we go by dates of recommendations to try to ensure that as much as possible we're capturing booster doses and not third doses. But it could be that some of these booster doses are misclassified as third doses. But going back to a previous commenter, I wonder if Dr. Klein could just clarify that we're not with the issue with the myocarditis and pericarditis in 40 and older with boosters versus primary series. When we did the primary series analysis, we were focused mostly on younger individuals, 12 to 39. So we actually have done a bit of a different analysis for boosters compared to primary series. And I don't think we can really say that those for the 40 and older, those are comparable because some of the work we've done for the booster dose safety monitoring in the 40 and older, we actually didn't do for the primary series.
Right. Thank you much for clarifying. Just to be more clear, for the primary series, we never reviewed the charts for over 40 for myocarditis and pericarditis. And that is meaningful because, as you saw in today's presentation, just around 40-45% are verified. So you really do need to review the charts for the older individuals to diagnose them and adjudicate them. So we haven't done a comparable analysis, which is why we couldn't compare rate ratios and rates between primary series and booster dose series, but as I showed you for the younger individuals. But we haven't done that. We never did that for the primary series. So it's a little bit, we're still sort of understanding what's happening with these older individuals in the booster doses.
Thank you. Dr. Sanchez?
I just wanted to get back at Camille's point because that was kind of my comment earlier as to whether we were seeing more myocarditis with the booster. It seemed like the differences that we had seen before with Pfizer versus Moderna may be mitigated by the fact that the second, by the Moderna booster dose being now down to 50 micrograms, where, the Pfizer's 30, and certainly less than the 100 that was previously done. So I'm just wondering, I know that there's still more analysis to be done, but I wonder if if the lack of significant differences between Moderna and Pfizer and the booster in the young individuals may be affected by the lower Moderna dose.
Thank you, Dr. Sanchez. So noted that it sounds like there would be additional information that would be helpful with regards specifically to the different dosage for Moderna. I don't know, Dr. Shimabukuro, is there anything else you want to add?
I think it would be challenging to do that analysis. I'm not sure we have sufficient data to draw conclusions about that, but we can continue to gather information on it. There may be multiple factors that are contributing to what we're observing, but I guess seems biologically plausible, so you can't rule out that a lower dose may be attenuating the risk for booster.
Thank you. Dr. Daly?
Yeah, I'm going to continue along this point, just so I'm sure I understand this. And I think this is probably directed at Dr. Klein, and this is sort of in response to Dr. Cotton's question. But I mean, I think, and Dr. Klein, please let me know if you agree with this or correct me if not, that, I think within the VSD is able to distinguish between a 100 microgram Moderna dose and a 50 microgram Moderna dose. And then there'll be two groups. There'll be immunocompromised individuals who received a third Moderna dose that's 100 micrograms. And then there may also be some immunocompetent individuals in the VSD that got, by accident, a 100 microgram dose of Moderna as their third dose. But that's probably really, really small. And so there probably won't be enough individuals in that group to say anything about the safety of myocarditis, the safety with respect to myocarditis, because the numbers will be so small, and then the myocarditis risk is pretty rare. But then in the individuals that are immunocompromised, there may be sufficient numbers at some point to look at the myocarditis risk in them. So does that all make sense? And Dr. Klein, do you agree with that?
Generally, yes. My only comment is that I believe I don't have the exact information at hand, but there certainly early on in our booster analysis, there was actually an issue about us not actually being able to distinguish the 150 microgram doses of Moderna within our systems. That may have been corrected in the meantime, but I'm not sure that we've always been able to, because I think there were some coding issues around that. But yes, but I will say that those people that we think were immunocompromised and received the higher dose earlier on based on earlier analysis I mentioned are not, we are specifically excluding them from our analysis now. So we have to go back and evaluate that as a separate analysis. And I'm not sure how well we'll be able to understand that, but I think it's a good point, and I think it's an interesting question.
Okay, thanks so much.
Thank you. I don't see any additional hands raised, so I think what we will do is move to our break. I want to thank all of our presenters for all of the information that was presented today in public meeting. We certainly appreciate it and the ability to review that data together. We will take a 10-minute break, so I'm going to ask if individuals will come back at 53 minutes after the hour, and we will convene the next session. Thank you.